to be here and to share this case of a girl referred for esotropia surgery. My name is Arif Khan, and I practice in Cleveland Clinic, Abu Dhabi. So, let's see. So this is a story of a 6-year-old girl who was referred for esotropia surgery. She actually had been previously seen by a retina specialist because of nystagmus. The family was told that the retina was normal other than the myopia. She comes in, she's high myope, she's 20/40 with her correction, but that's not the reason she's referred to me. She's referred to me for strabismus surgery. She has an esotropia of approximately 45 prism diopters. She has slight nystagmus, as we often see in patients with children with infantile esotropia. The fundus looks myopic, and cycloplegic refraction is comparable to her current glasses. So she had been previously seen by a retina specialist because of a question of whether or not there was a retinal problem, because with her glasses she had some nystagmus, and the retina was described as normal. However, when we specifically questioned the family, they didn't say this when she came in, but when we specifically questioned the family, the mother says that the child does very poorly in the dark, very poorly in the dark. And again, they didn't volunteer this information. We specifically asked because this child came in with very high myopia and did not correct to 20/20 with her glasses. So that's what prompted that extra question. Again, the information was not volunteered until we asked that question. Looking at her retina, it's certainly a myopic retina. And multimodal imaging of the retina is normal. Autofluorescence, OCT, the appearance, it all is within normal limits other than a highly myopic retina. But when we have a situation like this, when we have a child who has very high myopia and doesn't correct to 20/20, there are some additional things we should do. One is to ask the pointed question, and the other is to do electrophysiology. Electrophysiology is warranted here. And it's really the only test that can answer the question whether or not there is global retinal dysfunction in this child. There's no other test that can assess that. And I'm not going to go through the ERG, but let me just say this is the dark scotopic readings, and there's almost nothing. It's almost flatline. So she has no night vision, no scotopic function. And when in the combined response, normally, the second blip, which is the B wave, is supposed to be higher than the A wave, the negative blip. The negative blip is normal. That means the photoreceptors are normal. But the second blip, the B wave, is supposed to be higher than the A wave. You can see it's not. This is the so-called electronegative ERG telling us there's intraretinal dysfunction. So she has no night vision, no scotopic function. She has an electronegative ERG. That means there's intraretinal dysfunction. The cone function is normal. This girl has congenital stationary night blindness, and the only way we can diagnose that functionally is by doing an ERG. There are different forms, genetic forms, but basically it's the ERG that makes the diagnosis. Genetic testing confirms it. In this particular girl, she had biallelic TRPM1 mutation. She had recessive disease. Girls are allowed to get congenital stationary night blindness. There are recessive forms. It's not all X-linked males. There are a few teaching points from this case that I'd like to summarize for you. One is that, in general, children with only high myopia should have excellent acuity with the refractive correction. And if they don't, that's a red flag that we should suspect that there's something else going on. Secondly, normal multimodal imaging does not rule out retinal dysfunction. This patient had been evaluated by a retina specialist and told that there was nothing wrong with the retina. That's true structurally, but not functionally. 3, congenital stationary night blindness, which is a very common disorder in my experience, is only diagnosable by ERG. We cannot diagnose it in any other way, and it is an indication for ERG when it's suspected. And fourthly, unexplained subnormal vision in a child warrants an ERG. And there are different situations that can be diagnosed, which I'm not going to go through time. I'll just stop there and ask for the next presentation. Thank you.